doing 2 lectures. And
Thank you.
these all 5 excellent lectures are open to discussion. We have the 6 panels, Dr. Kang Ji-yoon, Park Man-won, Park Sang-don, Soyoung-hoon, Yang In-ho, and Jang Jae-hyuk. So please feel free to raise question or comment.
Yes, may I start first? My name is Jim Kang. I'm from Seoul National University, and I would like to have the question for Dr. Pa, please. Your talk was very impressive about the role of TAVI in young age patients. Can I understand? I have 2 questions actually. The first is, can I understand that the more importance of an ideal heart team may be more important in younger patients because these patients have to decide whether to receive surgery or TAVI, and if they receive surgery, if they should have any aortic root modification for future TAVI or else. And in the old patients, there's relatively lesser issues that we should consider when we proceed for TAVI.
Yeah, I totally agree. I think if you're dealing with a 97-year-old patient who's minimally active, surgery is not an option for them. I think in the younger patients, that's where the biggest consideration of surgery and surgical technique should be. And I think that the advanced techniques that we talked about, which are little used these days, partially because they're only used in other pathologies, apply a lot more to young people. And I think that the value that we can bring as cardiologists is having the discussion with the surgical colleagues about who would benefit from those techniques. And then it's, together we can quantify the risk for those patients and determine what the best solution is together. And I think the valve team works best where everybody works together. And there's no reason for us to send patients to surgery without involvement of the valve team and send patients to TAVR only with the valve team. So I think the valve team is essential at all levels, and CT scan should be done at all levels.
The second question is about your issue about coronary alignment and commissure alignment. Of course, the coronary access is a major issue that we should achieve commissure alignment, but the annulus, at the annulus level, is not a circle, and there is native commissures, and there's a geometry of the original annulus. So, to my opinion, I think that even if the coronaries are not at the middle part of the sinus, the commissure alignment may be more important to maintain the natural geometry of the patient. And actually, as interventional cardiologists, we have minimal difficulty in engaging slightly abnormal coronary osteums. So commercial alignment versus coronary alignment.
Yeah, so I think that it depends very much on what valve you're going to put in there. I think if you're looking at the larger evolute sizes, the level of risk for around the commissural post, it's pretty wide. The angle of risk is pretty wide. So that's when it's important to be very closely aligned. If that wasn't an issue, I would agree with you. And there is some data that if you achieve commissural alignment, perhaps you decrease the risk of sinus thrombosis, and flow dynamics are better. But I think this is a work in progress, and I think we're going to hear a lot more about this. And finally, so far we haven't had balloon expandable commissural alignment, but with the X4 valve, which is the next generation of SAPIEN, hopefully that will be achieved. The problem, however, with commissural alignment is that if it requires a lot of manipulation in the root, that can be problematic as well because it may increase your risk of stroke.
Dr. Lee, I have 2 questions. Actually, I was surprised the JEJU valve can be used in both severe AS and also the severe AR patient. So in Hong Kong, the JEJU valve did get approval for can be used in both severe AS or severe AR patient, right?
Yeah, yes, we actually follow the CE mark approval. It was approved by CE mark back in 2021 to treat both AS and AR. But because of the limitation of the devices, you know, it's very, very difficult to get the device worldwide. So we reserve the device to treat our AR patients for now. We have not treated our AS patients with this device in Hong Kong yet.
Why did AR patient showed very high rate of pacemaker implantation than compared to the severe AS patient in applying JEJU? So can you explain the difference?
Yeah, I think because you know, in AR patients, even with this valve, the recommendation from our proctors is still a little more oversizing than our usual TAVI device to treat AS patients. So I think first of all, oversizing is one of the contributing factors. And then you can see, actually we push the 3 locators to the bottom of the coronary cups so that when you expand, actually it's not really in a high position. I would say it's actually quite deep, at least 8 to 10 mm below the annulus. So if the membranous septum is short, then it might increase the chance of pacemaker implantation in the future. So what I have suggested to them is we try to implant higher. Although the proctors might not agree with me, next time we might try to implant higher. I do not push the 3 locators way down to the cups and see if this can actually reduce the chance of pacemaker in the future. That's something we have to explore more in the future.
Dr. Lee, may I ask you a question? When we see the morphology of JEJU valve or trilogy,
Yes.
locators are really important component to prevent regurgitation, just embolization toward left ventricle as well as distal embolization.
Yes.
But in terms of prevention of prolapse to LV, locator is definitely strong. But I'm a little bit concerned about the clasping power of locator to clasp the valve leaflet and prevent distal embolization. If you implant JEJU valve trilogy a little bit higher position, such kind of clasp force may be weaker. Is there any chance of distal embolization when you study the court registry of JEJU valve or trilogy?
I don't see any of the reported cases. Of course, that's the real worry. So that's why even with the proctors, with the company, they ask us to push the locators as deep down into the cups as possible. What I mean is try to like grasp enough so that maybe in the lower 1/3, then if we deploy, the chance of pacemaker might be lower. But this is something we don't know. We have to explore. But you are right, Dr. Kim. If the locators are too high, then you might not grasp enough of the cups, and then the valve might have a chance to embolize upwards or downwards. But I don't really see a lot of reported cases even in the registry.
Dr. Matthias, I have questions. I was surprised by your presentation. The beta flow have many advantages. First, very stable deployment process, and then very low pacemaker implantation rate and very easy coronary access. So if you have experience in Evolut R or the other self-expandable valves, so can you compare the performance of these valves, the beta flow, compared to other self-expandable valves?
Yes, absolutely. This is a very good question because both valves or all self-expandable valves have some point of contact, some similarities. But in this case, what we find in beta flow, the difference is the stability of the implantation. When you put a core valve, Evolute, or other self-expandable device as Accurate Neo, there are some movements during the final part of the release. Even with Evolute, we can see some upwards or downwards movements during the final part of the release. And that, in my opinion, is because of the shape of the device is not straight. The shape of the Evolute are, and we have seen this in aortic regurgitation case that have been shown by Dr. Lee. The shape of the Evolute R is not straight, it's tapered. So in this case, the BetaFlow device has a very straight shape in the inflow, and also the motorizing system is very stable. So in the final part of the release, when you choose the final depth of the implantation, this valve is very stable. So if you choose to put the valve very high, this valve will keep this depth. So in my opinion, this is the main characteristic. And also because the valve, the BetaFlow is very straight in all dimensions, from the smallest valve to the biggest valve. Also, there are some experience in aortic regurgitation using BetaFlow, and that's why, because it's stable, it's straight, and the radial force is very strong. And that is, for me, the main difference between other self-expandable devices.
I have a question to Dr. Matias. Mucho gusto. Bienvenido a JEJU VALVE. Gracias por su muy buena presentación. Yo tengo una pregunta.
Muchas gracias.
Yeah, I have a question. You did pre-dilatation in most cases in beta valve, right? And you showed us the lower instance of pacemaker instance compared to Evolute R. This means that the radial pulse of the vital flow is much soft than Evolute R, or no? Yeah. How do you feel the radial pulse?
No. I think that the radial force is bigger. In BetaFlow is bigger than other valves, other self-expandable valves. I think that is the self-expandable valve with biggest radial force. But I think that there was no difference between Evolute and BetaFlow in terms of conduction abnormalities. But what we want to show is that if we use gas overlap technique, we can obtain the same conduction abnormality rate with BetaFlow than other valves. Because if you think that you are using a valve that have more radial strength, maybe you can think that it comes with more pacemaker rate, but it's not like this, and that is one I want to show. If you use the correct gas overlap technique and you plant the valve, this valve in gas overlap technique, the rate of pacemaker is almost the same that other valves, but the radial strength is bigger.
Matthias, I have a question regarding your BetaFlow Liberty valve. You mentioned the morphology a little bit different from the Evolute series, but that was after deployment. During deployment, how is it stable than Evolute? Just motorized deployment, manual deployment, I don't see any big difference between two styles regarding the movement, downward or upward movement during deployment. Is there any other hidden secret for the stabilization during deployment, such as central spine structure or other hidden secret? I don't believe just motorized deployment is a kind of key factor to stabilize the valve system during deployment.
It's a good point. I think that it's a combination of things. What we find in the motorized system is that there are some transfers of the movement of the second operator. When the second operator opens the valves in some part quickly, there are some transfers of the movement of the second operator to the first operator. And this is one point. When you press the button, there are no transfers of movements. And the second point is not because of the delivery. I think that is a combination of the device, the shape of the device, and also the radial force of the device. In my opinion, I have not the answer because I'm not involved in the device and the construction of the valve. But what I feel, because I have done 55 or more, almost 60 cases, and my feeling is that it's very stable. I have not bad experience in terms of embolization. Usually, we don't need to reposition the valve. The need of reposition is less than other devices. So I think that there are not one factor that make this device more stable. I think that is a combination of factors. Some factors are the delivery, some factors are the device, and some factors are that we get this device with a bigger learning curve of other devices. So we are using this device with high experience with other devices. So maybe these all things combined make that impression.
So any questions from the floor? So I'd like to ask you, Dr. Pop. So in Korea, the heart team discussion is a mandatory step to get reimbursement. So, but your team do all the heart team discussion in patient receiving SABA or TABA. So is the in United States most hospitals adopt this kind of heart team discussion, or in your hospital?
So in our hospital, we have a very good relationship with our surgical colleagues, and we do discuss all cases, whether they go for surgery or whether they go for TAVI. That's certainly not the standard in the United States. I think it should be the standard. I think care for the patients would be a lot better. There is talk in the United States of actually no longer requiring two operators, a cardiologist and a surgeon, and I think that that's a major problem, because I think that by far the most important thing that we got out of TAVI has been the fact that we're finally working together with the surgeons, and I think that's a wonderful thing that should be encouraged.
Thank you, all the speakers and panels.
Dr.
And
Zhang,
yeah. Oh,
can I have just one brief question
okay.
for Dr. Pop? Dr. Pop, I deeply removed your nice lectures. I have just one question about the heart team discussion process in United States. Actually, in Korea, the heart team discussion is one kind of mandatory process to do TAVI. It's actually a little bit, unfair decision system for interventional cardiologists compared to the surgeon. So anyway, we are struggling this kind of, some official the steps. But anyway, we will understand that, we will choose the best option to treatment for patient. But in Korea, there is some kind of, some competition of two cardiovascular surgeons and then two interventional cardiologists and echocardiography step and radiology step and then the anesthesiology step. If there is just, even just one rejection to do TAVI, it is impossible to do TAVI, actually. How about condition in US? If there is some kind of discordant opinion in between the doctors, is there any kind of options to do TAVI in United States?
Yeah, so technically we have to have the agreement of a surgeon and a cardiologist to move ahead. the reality is that I think the valve team works the best when everybody has the patient's best interest at heart. And I think the way to get to this is to not fight with one another, but rather look at that. My most recent case that was sent for surgery would have been probably sent to TAVR in a lot of other centers in the U.S. Was a 69-year-old woman who was morbidly obese and had a very small annulus. She wasn't Asian, but she had an extremely small annulus. And had she not had a CT ahead of time, she would have probably had her chest opened, and once they realized on the table that she needed a 19-millimeter valve, she would have gotten a trifecta valve. In this case, we actually stopped and we talked to the surgeons and said, despite the fact that the patient is 69 and despite the fact that she was told that she would probably get a TAVR, we recommended to the patient that she get surgery. And it's much stronger recommendation when it comes from a cardiologist than it comes purely from a surgeon. And I think we have that level of relationship that the surgeons know that we will send to surgery patients who would benefit from surgery, and conversely, they will send to TAVR patients that would benefit from TAVR regardless of age. So we're really looking at the patient benefit.
Okay, Dr. Bob, just one more question. Is there any room to do opinion from patient themselves or their family guardians? Actually, there is no process in the shared decision making in Korean heart rhythm discussions. It only depends on the decision of the doctors. And so there is no room for patient or guardians. And so is there any room to get in the interrogation with the patient and family members, the preference?
Yeah, there is certainly a lot of role for patient preference. That being said, I think the situations where I've gotten most in trouble and I've gotten the most complications have been situations where patients have gone against the valve team decision. And in our situation, we said, if we make a recommendation and the patient doesn't take that recommendation as a team, then we tell them rather go somewhere else and get your procedure done somewhere else. We're not going to do the right thing, the wrong thing. But I think obviously patient preference has to be taken into account, and it's very important.
Okay, thank you.
Your answer is you achieve 100% agreement. The real question is, if you cannot reach agreement, how can you do? That was the question.
Yeah, so if we don't achieve agreement, then we stop. And the most recent example that I had, we had a cardiologist who's on our team, and we're trying to be very democratic. And the cardiologist absolutely insisted on doing a procedure in a patient where we felt it was not recommended. And the surgeon actually refused to sign the consult, which blocked the procedure. We had a long discussion, and finally the cardiologist relented, and we were able to get an MRI to prove whether the procedure is necessary or not. But I think we've never ever taken a vote in the valve team. We always try to achieve consensus, and unfortunately, it depends very much on the personalities. But I think that's where the guidelines have to be adjusted to reflect the importance of the valve team going forward. I think it's tough when you have the surgeon being the ultimate decision maker. I think it's much better to have the entire team being the decision maker.
Making a friendly heart team is the answer. Yeah, very hot the discussions. The session went by very quickly because it was very fun. So I like thank you, Dr. Matthias and Dr. Lee, and also Dr. Andre Pap. So thank you. We have to close this session. See you this fall or next year by another symposium. See you. Thank you.
Thank you.
Thank you very much.